So I'm talking on behalf of quite a few colleagues this afternoon in this session on our development of a patient-reported outcome measure for people living with HIV here in the UK, and this was funded by MAC AIDS Fund and the St Stephen's AIDS Trust through BEVA, and BEVA are one of our partners along with UK CAB and many other partners, and where's Cleaner? Cleaner was part of this as well. Thank you very much, and Jaime and Brighton. So we've got a number of people in the room who've participated in this work. So we do have a rehabilitation strategy from the WHO, and they are called concrete steps, which is always very encouraging, isn't it? That we should be integrating rehabilitation within the HIV care continuum. And they make the very clear statement that clinicians and healthcare workers are expected to manage the increased complexity of HIV, and they make a number of recommendations around policy, inclusion for people with disability, and making sure that we provide accessible environments. And they also provide some examples of practice. And while it's always great to see innovation, actually if this is a series of concrete recommendations, you would hope that they'd be based on evidence. The problem is it is innovation without evidence, and that's kind of where we are really. A few of the exceptions I would note is Kelly's done a couple of really nice systematic reviews on aerobic and resistive exercise for people living with HIV, and I'd recommend you have a look at those. So what about problems and concerns? So you just missed that. You want to take a photo. I've gone back for you. There you go.
Oh, thank you.
So what about what matters for people now living with HIV? Okay, so, well, we know all of this stuff. This is not new. HIV is considered a chronic condition with near normal life expectancy, depending on which new paper you read. We also know in the UK that health-related quality of life for people on treatment is poorer than that of the UK general population. We know that there's a continuing high symptom burden, which includes problems which may be physical, psychological, social and spiritual, and there are emerging complications which also need to be managed, and we've talked about a lot of those today. There's a really nice paper a couple of years ago that said the contribution of physical and mental health to health-related quality of life is our current critical challenge in HIV medicine. It's the thing we really need to be considering. And when we asked people living with HIV here in the UK, this is some work I did with Gay Men Fighting AIDS, we asked them about their experiences of care, and it was a study called Positive Futures. What do you need to engage in a positive future? And the perception of these gay men attending HIV care services in the UK was that routine care does not address their issues of physical, mental and social well-being that matter to them. And do these things like physical and psychological problems matter? Well, yes, we've done a number of cross-sectional and cohort studies here in the UK showing that physical and psychological symptoms are associated with the things that matter, like sexual risk-taking, viral rebound, poorer adherence and poorer self-rating of health. So these things do matter. And also I would note we did another study showing that symptom burden was associated with suicidal ideation. So just to kind of bring us to some clear definitions that are commonly accepted. First of all, I find this so helpful. I probably cite this at least once a week in meetings or papers. It's really important when we think of this idea of health. It's not a medical model that we're applying. It's the same idea that the WHO stated in 1948, which is that health is the state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And this is really important that we keep this in mind in our work. And then we think about health-related quality of life. The Centre for Disease Control says health-related quality of life is an assessment of how the individual's well-being may be affected over time by a disease, disability or disorder. So this is where we're coming from. So how about patient-reported outcome measures? What do we know? Well, we know that we need to have more person-centred care for people living with HIV. It's very interesting, you know, HIV in many ways, of course, has been the Rolls-Royce of healthcare, has been traditionally more person-centred than other disciplines, but that doesn't make us perfect, and it's always important that we're considering practice and how we can improve. And there's some great studies by Amy Justice in the US showing that actually in a routine HIV medical appointment, the practitioner will miss patients' needs and symptoms, particularly non-physical ones. So she got patients to complete a checklist before they went in to see their HIV physician, then asked the physician afterwards what were your patient's problems, and the physician detected around a third of them. So this has been really, really important studies. So if you take a routine PROM, a patient-reported outcome measure, And you use that in routine practice. So at the beginning of your assessment or prior to the patient coming into the room, they've completed a brief, valid patient-reported outcome measure. What you have is a very quick snapshot of a full assessment and identification of the main problems that matter to this patient in front of you right now. So PROMs actually, in the evidence, quite good at helping clinicians to identify problems, improve communication, and can improve outcomes for patients if they're used in routine practice. That's the issue. Nothing's going to change if you complete a PROM and then put it in the patient's file and put it in a drawer. That changes nothing. If you use it to direct care, which is what happens in this building, so the palliative care team here use the palliative outcome scale at every clinical appointment. When they sit down doing their MDT in the afternoons, they flash up on the screen the patient's individual scores over time, they discuss them, and they plan their care management around those scores. That's what makes the difference. Within the NHS, there's a policy drive for PROM use, and when we did some initial work with UK CAB and a number of community groups to first kickstart this programme of work, people living with HIV and clinicians were very clear that this is what they wanted, a specific PROM that is valid and useful in routine clinical practice. PROMs are increasingly being used in clinical trials, but not so much in routine care. And there are a number of patient-reported outcome measures out there, things like measures of depression, stigma, adherence, but not a clinically driven, single, multidimensional item of a core measure of the things that matter most to people living with HIV. Because, of course, you want it to be fairly brief. It needs to be valid, but it needs to be fairly brief as well. Because if you take valid measures for every outcome, you're basically going to walk into your clinical appointment with the telephone directory of questionnaires, and that's never going to be appropriate. So there isn't a brief person-centred PROM that reflects the range of outcomes that are relevant now to people living with HIV to help drive and evaluate care. So what we aim to do with this study, the positive outcome study, was to find out the priorities of adults living with HIV in terms of measuring their priority outcomes in their NHS care, to deliver that measure with a multi-professional group, and then also, really importantly, work out how do you implement that in routine practice to improve person-centeredness. A number of systematic reviews have showed that actually if you're going to implement a PROM in routine practice, doing this groundwork, getting teams on board, getting people on board and understanding why it might matter is absolutely crucial. So it's a qualitative study, and for those of you that are interested in health measurement science, we use the COSMIN taxonomy for developing and validating health measurement scales and the Rothrop guidance on development of items. So the methods, here's the Rothrop model of health scale development. So it's qualitative interviews with people living with HIV and HIV professionals, which is really important because they're going to use this tool. Also, very importantly, commissioners as well, because getting them on board is really, really important. Developing a conceptual model, and then the item generation, which was a large team spent a day, and some of the people here now spent a day talking through from the perspective of nursing, medicine, social work, psychology, lots of people living with HIV in the room as well, psychometricians, so we had a large multi-professional team building the items on the data and the existing literature, and then refining those in a second set of revisions, and then doing cognitive interviews to make sure that there was interpretability of those items. So I'm going to talk today just mainly about the qualitative data, and what we found, of course, is that people's priority outcomes are multidimensional. What I've pulled out today is the parts of the data which are most relevant to this discussion on rehabilitation for people living with HIV. So here's our sample, 28 people with HIV, 21 professionals and 8 commissioners from London, Brighton and Dublin. So, what does this allied health professional say? I think the word it misses is health and well-being. This is what's missing in the routine clinical assessment. I think introducing the word well-being will enable the gates to open on actually how you feel. I think being asked those questions about emotional well-being, successful living, successful ageing, and those sorts of things are important. And this is really key because, of course, what we ask in assessment is what sets permission for the patient to discuss. We set the agenda. What matters to you? So by actually having a multidimensional assessment that asks the range of core outcomes that might be relevant is absolutely key in giving permission for those things to be raised in the room. But it's really important that clinicians take that leadership. this man is saying, I think in general terms, I'd like to hear them say, how is your physical health? How is your weight? How is your mobility? Is there anything going on there? You want what they used to call signposting, what we used to have years ago, like in counselling. So this guy is saying, I need the clinician to take the lead here and give me permission to raise these things that really matter to me that actually I may not raise myself because I don't think they're important enough to the clinician who's assessing me. However, we did find some conflicting priorities in this data, which I think is quite interesting. This guy says, I think in general terms, I'd like them to hear that, how is your physical health, your weight, your mobility, is there anything going on? But you contrast that with what a commissioner said, and we asked them what outcomes matter to you as an HIV commissioner. I'd expect adherence to be discussed in their clinical appointment. I'd expect them to be updated on their latest blood results. I'd expect partner notification. So we've got a very different view of what outcomes matter, I think. And this is really, really important because we need people to commission what matters. So I think having people on board in this study is very, very important. This doctor said the other thing is that people don't ask about their function and how people are managing at home. We need some way of capturing how people feel they're managing their everyday tasks. Because this is really important. This doctor recognises that we could do this better. So I think there's great potential for us to address this. And when we ask what's important, what might we value, things like fatigue, daily function, what can you or can you not do in your daily function? How does it affect what you can do? Because that's the most important thing. That's probably the last thing we actually ask. But I think that's changing slowly. So fatigue, ability to do things like go to work, go to the shop, do your general functioning, general social functioning, ability to go out. So these are things that we certainly can do better. And building on the work that Patty described earlier with this idea of episodic disability, I think it's really important that we're routinely asking these questions because of the episodic nature of these problems. So could we commission such services? Do we think it's possible? Well, actually, it's always good to highlight the positive and the opportunity. This commissioner says, yes, we want something about the impact of HIV, the condition, your physical health and what that means. Antiretroviral meds, diarrhea, frailty, these kinds of issues. How has the whole experience and impacted on your confidence to go and do things? So I think these are really important here. We do have a commissioner that understands that things might be different. One of the things that you probably hear this all the time, I'm quite personally interested in this idea of the stable patient. We hear this all the time, they're a stable patient. This nurse says, apparently, according to the authorities that be, the powers that be, there's 80% of people live with stable HIV. We don't see that. The HIV is stable, it's everything else that's not. And this is always my concern when we focus on commissioning the vast majority of services for the stable patient. We actually mean medically stable in terms of viral suppression and adherence. Actually, the fact that maybe somebody's got enormous social, and Cleone, I mean, you talked about this a lot with your Dublin cohort, people have enormous social problems, psychological distress, social exclusion, poor function. All of those things actually, for me, are what a stable person's about or not about. So I think we really need to think about that terminology. So this allied health professional gave us kind of a sense of what things might look like if we did it better. I'm going to say people's function, how people perform their usual activities and what's meaningful to them. We need to ask, are you able to participate in the things that are meaningful to you? And I think that absolutely captures what we should be doing in person-centred care. Actually, I'd note Alessandra's here, who's a PhD student who's just started doing a PhD on the meaning and practice of person-centredness in healthcare. So it's certainly something we're going to be doing a lot more work on. So whose responsibility is this? This is another debate and argument which I'm sure you all recognise, and at the patient level makes no sense at all. So the question is, could it have been related to the HIV? Could the presentation be HIV related? Most GPs will think it probably is. Then it's pushed back to the HIV physician, which is what they want to get away from. So the problem is we're asking patients to be able to understand the etiology of their problem and who's the most appropriate person to present this to, and then they're going to get bounced. So this is incredibly complicated that we expect people to understand the nature of their problems and who's best to manage them. Help me to keep myself well. Independence is very, very, very high up on the list. My mobility is restricted, but learning to live with the restricted way I have to do things now compared to a long time ago. So it's independence, mobility, which is deteriorating bit by bit. Osteoporosis was just as bad as the HIV. I was losing my independence from osteoporosis because I had fractures, breaks and things like that. My mobility was completely gone. I was lying in bed and I was sitting on the couch, and then the mental health was beginning to creep up and things like that. But with the right counselling from the hospital and the right support, went through the process again. Let's take this a step at a time. Let's take our time. I'm fortunate enough that that support is there so that I can keep myself well. I mean, the NHS is really focusing on self-management, and in fact we've got some work with UCL at the moment that we're leading on self-management of pain for people living with HIV. Actually, if you provide the right services, people do want to self-manage. But this guy does recognise that he's fortunate because he's been able to access this level of support. So if we've got detailed assessment, hopefully we can get care coordination. And I noticed in somewhere this week that the National AIDS Trust is doing a project at the moment on care coordination, which I think is really, really important. And hopefully this kind of centralised assessment, person-centred assessment, will be helpful. I think if it's imposed on you, like on a questionnaire saying, right, we've dealt with that, okay, let's have a little look at else what's going on. How's your mobility? How's your sleeping pattern? How's your diet? Do you need to see the dietitian? Do you need to see the PE? I've had all of those things on my own. I've had to ask different departments, and this is the problem, isn't it? I think we heard that this morning. I think Jaime showed us that lovely model of all the interactions with the professionals, which is incredibly wasteful, I would suggest. So actually at the individual level, this is really, really hard to navigate. And I think in person-centred care, we really need to carefully ask, what are the goals of care? If that commissioner was right, and the goals of care are viral stability, partner notification, where does this guy sit? That's what I was doing then. I've got to stop all of them. You're thinking, how will you survive your life? That's the most important for me now. He's talking about his very survival. So I don't think a medical model is enough to make this guy feel like he's going to survive his life. Somebody needs to take a person-centred approach with this person. So just to give you an idea of what we've come up, we've got a 23-item person-centred PROM which addresses all the main domains that were described to us, including physical, cognitive, psychological, welfare, social and information needs, with a global item of assessment of well-being, which people were very keen for us to include, as well as free text options as well. We do that in a number of other outcome measures. What is it that matters to you right now? And each one is scored on a Likert scale, and there's some work happening right now, and I think in fact Jaime and the team up at Guy's are doing some more work with this right now. So that's where we are with the person-centred outcome measure. It's very exciting. It's on an app also with the Emerge project led by Jenny Wettam in Brighton, and we're looking now on moving on towards getting the final validation data in, but also looking at generating some demonstration sites to really incorporate the outcome measure into routine care to drive up quality and person-centeredness. So it's something that people wanted, both HIV professionals and people living with HIV. They wanted to drive, evaluate and improve care, and also people told us that they would feel empowered at the patient level. If I'm driving the encounter with this patient-reported outcome measure, that empowers me. So we've got face and content validity. We've done it in line with the best scientific principles of health measurement, development and validation. And what's come really clear in the final item, which is relevant, the final items which is relevant today, is that physical function and social participation are core self-reported domains in this measure. So thank you very much.